Welcome to Solutions Over Problems. Today's episode is the nursing strike that will occur on May 15th in coordination with the canceling of health insurance. And this is to provoke nursing reform across the nation. I told you guys I wasn't the admin. Guess it's time to prove it in this video. We already have more or less proof of concept on which healthcare model works best. And this is pretty much the saying in the medical world called the West is best. And this is in regards to licensing laws and nursing staff ratios. And this is primarily a nursing reform video. And the end of this is also going to be why different provider types such as PAs and NPs even came about because of the American Medical Association just sucking. Step one is the federal government should implement California staffing laws as a requirement to bill to Medicaid. If you attach this provision to Medicaid, Medicare, you will force the entire country's intensive care unit process into compliance. And by forming that, you will decrease the rate of demise. In some of my videos, you'll notice the purpose of preserving as much population as possible that we have due to population decline. If Japan can outperform us on life expectancy, life quality, and overall health outcomes, we don't need to invent the wheel. Just copy what's working. Stop being... Anyways. Step one, California nursing laws. Okay. I don't want to get a cease and desist letter, so I'm trying to think about... There are for-profit healthcare institutions that will push nurses to 1-to-8 ratios on floors that are inappropriate for the level of care. But they will compensate these nurses with higher money, pay raises, than is typical of other hospitals. These nurses are taking on a large amount of personal risk due to their license exposure. And also their patients are unknowingly being exposed to basically less attentive healthcare delivery because you're receiving 50% of someone's attention at that ratio. That should be a 4 or 5 at max of recovery, excluding rehab units. We're actively progressing toward sentinel vents and sentinel vents is when a patient review occurs due to a death that may or may not have been preventable. They're dumping all this crap on nurses and blaming them for sentinel events when actually it is an effective, deliberate, coordinated effort which nearly meets the definition of a conspiracy to provide the minimum level of care to give the illusion that you are getting the highest quality care. That's what we'll say. And this particular profit vehicle loves minimally qualified electronic health records, which is our next topic. Why are we teaching nurses nursing health care plans? Because they don't do them at all. They follow the orders of the doctors and they do them. There is almost no autonomy in nursing care at all anymore. This is because doctors' liabilities and so on and so forth. About the most you can get for autonomy of nursing is knowing when to withhold a medication due to unmet parameters. That's about as far as you can go for knowing when to withhold an intervention, according to a doctor's order. Again, these electronic healthcare records are contributing to education cost of onboarding people and basically continuity in care in training models. There are some EHRs that are better, but the majority of nurses pretty much agree that Epic Healthcare, EHR, electronic health records are the best. So what you want to do is you want to commit eminent domain on Epic Healthcare systems and seize it for the US government. Don't care how much it costs, write a check, don't cry, I don't care. You spend $80 billion in the government today on probably garbage. So yeah, just write a check and buy it. Then you're going to force that onto every hospital into Medicaid, Medicare compliance. So now every hospital must have the same streamlined EHR of Epic Healthcare. This can be reverse engineered into medical schools. Medical schools then learn how to chart on a system that will actually be consistent with their training. The same can be said for nursing, PA. Basically, all of your healthcare professions can now be reverse trained into their training element of EHR of Epic. And you can streamline the process of this is the system, learn how to use the system, rather than this is our system, learn how to use it until you go somewhere else. Because you have to reduce cost to education of healthcare professionals. You have to reduce cost to hospitals so they don't have to be freaking grimy and be required to pay for pretty much effective healthcare systems. And you want to reduce false data sets because of people using garbage healthcare systems. If you've worked at a 3-letter for-profit healthcare institution, fairly nationwide, and your EHR looks like a typewriter, you know you will likely never find anything you are looking for in there because it is utter garbage. The double charting, the uncoordination of care is just unbelievable. The EHR itself is causing uncoordination of care because it is so unnavigable. Far we have California nursing staffing laws, eminent domain of Epic Healthcare Systems. Next is nurse practitioners. Nurse practitioners' autonomy should not occur at graduation, and if you think you are good enough to do that, I'm sorry, but you are unaware of what you do not know. Colorado is a better model to accept with a carve-out. Colorado requires 4,000 hours before a nurse practitioner may conduct independent care in the areas that they've been licensed. That's 2 years. Just deal with it because you don't know what you don't know. And if you were the only person in the office, there are times for that, but not if you're sitting in the center of Denver. So the carve out for this 4,000 hour requirement is basically what are medical access deserts. That 4,000 hour requirement, if there is no other provider to whatever each state determines a medical desert should be, there is a bias in this medical desert from healthcare data. And what this is you have the American Medical Association who says they are trying to protect their patients from what they call mid-level providers, which is basically nurse practitioners, therapists to a degree, and PAs. And during World War II, there was a research study done on airplanes that returned from flights. And they said these are where the planes are damaged the most, we should reinforce these. Einstein told them that this was an observation bias because, well, it's actually survivor bias as well, and research data. And what it basically says is where the bullet holes hit planes that didn't come back are the more important areas to reinforce. Because if you get shot in the engine, your plane doesn't make it back to become a data set. And so we're getting skewed data around the country because you got nurses that are 1 to 8 on frickin' trauma floors, and at other institutions that are magnet certified, they're at 1 to 4s or 1 to 3s. On ECMO, you're at least a 2 to 1, depending on the status. And this is skewing data so much that the data sets themselves are unreliable based on disease outcomes and etiologies, especially in hospital stay times for disease etiology. Because if you have a patient who is 1 to 8 on a nurse or 1 to 4 on a nurse, you might as well bifurcate the data on what was the nursing ratio of that patient while they were in. And then I want you to find out how long that hospital stay. In addition to that, I want you to find out what is the hospital stay of surgical denials of Medicaid and Medicare or insurance in general of the doctor's initially requested intervention. So I had a patient one time. Doctor wanted to do a BKA, which is a below the knee amputation, because the foot was becoming necrotic. Obviously, I can't get into all the details, patient privacy. So the doctor wanted to do a BKA right out of the gate. From experience, saw that this wasn't going to work. Take a BKA. Insurance denies. does a above the ankle amputation. The disease of his leg at the wound bed does not have sufficient perfusion. Insufficient perfusion causes cell death at surgery site. Individual goes back to surgery second time, does a BKA. But now the patient has been in a surgical recovery state for at least 30 days at this point, following second surgery, BKA. Doesn't have nutritional supplementation due to age, perfusion, etc. The knee becomes a septic joint because insurance initially denied where the surgery wanted to occur at. The knee becomes septic, requires an AKA, so above the knee amputation. Patient finally recovers, infection clears, perfusion is found, leg is stabilized. That patient was in the hospital for 84 days, had 3 surgeries, and the insurance denied the doctor's initial assessment to do a BKA, and the insurance thought they were going to save money by denying the BKA amputation. 3 surgeries later in 82 days in the hospital, do you really think you saved money, you idiot? The seething hatred I have of health insurance and health insurance denial, whoever you are, if your job is health insurance denial, well, I can't say what I want to say to you because you're just disgusting. The data sets are being skewed by observer and survivor bias because non-uniformity in healthcare delivery models. There are patients who do not have access in medical deserts to any medically trained professional, and they are not surviving because there is no access. And the AMA looks at the plane that shot up and survived because they are their patients. The red dots on the plane are the ones they can see. But the AMA is also ignoring the patients who never arrived as patients. And this is where the observer survivor bias is willfully disregarding. Because if you can get a medical degree and you can't understand that you have a survivor observer bias in your data set for your patients, like I don't care about your patients. There are people that are not patients anywhere, that are not managed by anyone. Well, what are you going to do about that data set? So build you a state-by-state rural exemption of a medical desert. It can either be by driving time, transport time, distance to critical access infrastructure, healthcare. But let's be real. Like if you're telling me that someone without access to healthcare at all is better off than having a nurse practitioner with less than 4,000 hours, at what point is something better than nothing? Because under emergency guidelines, scope of licensure more or less disappears. So, where did all these problems come from? Here we go. American Medical Association. Prepare to get chewed. Nurse practitioners and PAs exist because those individuals have already worked in or near the medical field, and the doctors they work with tell them not to become doctors. Because at most, you're going to be dissatisfied with your profession because of insurance that you won't fight because you're too tired from being obedient into the system. And the people who run the system don't mind the system because health insurance employs more doctors than hospitals do. So maybe if you really wanted to end, as an American Medical Association, health insurance, maybe you just stop working for them. Frickin' cowards. If you don't like nurse practitioners and PAs, maybe do something crazy and, make MD and DO programs actually affordable so that when everyone graduates, they don't become debt slaves or go looking for a title zone to work in for public student service forgiveness because you're running the debt through the roof and doctors are so high in debt slaves by the time they graduate, the return on their investment is almost negative for their entire life. Like, if the AMA is so adamant about mid-levels doing what they want to do, you could fix it by making medical schools actually affordable, accessible, or anything else. But has that happened? You've had all the time to make that happen. So what's going on there? You think someone's going to choose to become an MD for $300,000 in debt by the time they're done with their residency versus going to NP school and picking up $120,000 and then working for less money but getting to cash flow faster, or PA? You guys are delusional if you think that your model of medical school is even remotely accessible. Because every NP and PA I know would have rather been a DO or MD because the education structure is better. But where's your access? If you reduce the cost by 50% but double your class size, you're going to make the same freaking money. You're complaining about a doctor shortage, but you're not increasing the seats in your own colleges of medicine? Who's to blame? It's you. The AMA is the reason for the rise in NPs and PAs and every other kind of mid-level provider that you guys say are mid-level. And it's because there's no frickin' access. And the access that's denied, the barrier to entry, is time, because people don't want to give away 8 years of their frickin' life. And B, it's money. So if the AMA wants to fix this problem, their mid-level provider problem, well, reduce the cost of med school. Pretty sure research has shown that there's no difference in outcomes of 3-year versus 4-year medical schools. So reduce time, reduce cost. Hard to give up a year of tuition though, when you go from a 3-year medical school to a 4-year medical school. Hard to give up that tuition, eh? Don't blame other people for the problems you created, because these licenses wouldn't exist if there wasn't a need for it. So stop complaining or fix your own frickin' problems. So if the nursing strike starts on May 15th, in conjunction with individuals canceling their health insurance policies on May 15th. At the same time, ladies and gentlemen, you're a captive because everyone assumes you won't stand up and take back what's yours. And it's your professions. It is your professions. You will spend more time in your profession than any other thing you will do in your life. Why are you giving them the control? You're not stupid. You're not a coward. And I know you care, even if you become calloused from seeing how the insurance and the doctors work, from how the health insurance works, to how the hospitals will understaff you. What are you waiting for? Are you waiting to be told to stand up and take your profession back? Well, congratulations. On May 15th, start the coordinated strike against health insurance companies and against hospitals. Nationwide nursing strike. Stop giving away your profession. Stop letting them staff you at 1 to 8. Stop letting them make you use electronic health records that are detrimental in the delivery of care to your patients. Stop letting them do it. And you can start on May 15th. Let's see how this goes. I think I'll give you enough headway to let you know it's coming. No real excuse for saying you didn't know.